Yeah. Good.
No problem.
He's 29 now, but again, he's together with his very close friend. Yeah, really loving. They are really. Yeah.
Yes, you can start right away.
I'm sure.
Hi, nice to meet you. Great. Very wonderful. You there? I've heard a lot about you from. Oh, you mean your phone?
It's
Actually, a friend of mine in Australia, but he's going for about 2 months. Totally nailed it.
Oh, no. Sorry. Come on. That's not enough then.
Good evening. That was really effective. So, those of you who don't know me, there's a number of faces who I recognize very clearly. I'm Professor Brendan McCormack, and I'm head of the divisions of nursing, occupational therapy, and arts therapies, which of course includes music therapy. So, Philip asked me along to introduce this lecture series, which I'm really delighted is actually happening. I still come as new as head of this division, although I can get away with that for about another 2 weeks. When I hit the 12-month mark, and then I'm no longer able to say that I'm new as head of the division. But I've been at QE for 5 years, but for the first 4 of them have been head of nursing, and then just short of 12 months ago, became head of occupational therapy and art therapies as well, which has been a real joy to kind of just start seeing how we can move things along, how we can join things up, how we can start to work more collaboratively, how we can start to build new things, which we're just starting to get to the point of doing that, which is very exciting, actually. So, although I'm a nurse, you have to forgive me for that. Most of my career I've worked in mental health or in dementia services. So working alongside occupational therapists, art therapists has been just normal day-to-day practice, actually. So it's not something that in any way phases me about how we integrate all of these therapeutic approaches, and particularly now when there's such a focus on non-pharmacological interventions, that I think is really exciting, actually, what's happening with the art therapies in particular. And it's very much my agenda to capitalize on that and to not just build on what we have, but to actually rebuild the art therapies more broadly here, because to some extent we're neglected a little bit. So so that's where we're at, kind of more strategically trying to make the most of all of that. And as part of that, it's really exciting that this lecture series is happening, and that Sanna's kicking it off. I've heard about you a lot from Philip and others, but and seen some of your work, but it's lovely to meet you. So that's really good. And music therapy has been at the heart of the art therapies here at QMU. And I know that it's been a really interesting journey for music therapy here, particularly under Philippa's leadership around taking probably what might be seen as a less traditional approach to the whole endeavour, and challenging the boundaries and really looking at it slightly differently, and looking at how we can do things differently and not necessarily buy into the status quo. For those of you who do know me, that takes every bone in my body, because not working with the status quo is possibly how I've built my own career. So, so it's great that that is actually happening, and I think has now really established itself as a proper psychodynamic-based music therapy program that is challenging boundaries of how this kind of practice happens, and that is fantastic. And as part of that, I think not just kind of really being driven by our education approaches, but also by the research. And the team is a very small team, small in size, but massive in productivity. But actually, what we need to really do is invest more in the research side of things here now as well. And that's why it's really good to kick off a lecture series like this and to have that as an integral part of what's delivered, because that's where some of the questions and the interesting things start to emerge from. And then people like Yorgos and Philip and others can start to really kind of get hold of them and really build on what's happening. And again, that is starting to happen, and it's really exciting that that is happening. The other thing I can't help but mentioning Yorgos, and you must mention it, and of course I will mention it, is the fact that we're going to be hosting the European Music Therapy Conference in 2022. Which I gather is that an announcement? Yeah. We should all go, yes. Which I gather is a kind of a 30th anniversary of that conference. It takes us right back around to where it's originated from in the UK. So it's brilliant that it's coming to Scotland, coming to Edinburgh, and the QMU and Yorgos and Philip and colleagues are the hosts of that. Really, it's a huge achievement, and I know you guys have worked really hard at making that happen, and it's no small feat to get a conference like that. I've just been working with this is a sad story, the opposite of this one, which is we've been trying to get the International Association of Geriatrics and Gerontology, the European region, here, because I'm speaking at that in Gothenburg in a few weeks, but we've missed the deadline by 1 day. For our submission, we didn't tell us there was a deadline for that to submit the time, so we missed it by 1 day, and that was going to come in 2023. So it would be very exciting. So anyway, that's my sad story. So, we'll hope for 2027 instead if we're all still alive. Maybe not here, but anyway. But it's brilliant that music therapy is bringing that here. So I'm not going to say any more and delay you. As I was saying to Philip and Sanna earlier, I can't actually day to lecture because it's actually my wedding anniversary. So it's my duty to go and grab the food and the champagne and get home as quick as possible. So unfortunately, I can't stay to hear you speak. But again, I'm delighted that this is happening. I know it's been live streamed, I think. So there's probably a lot more people watching it elsewhere. And have a good evening and enjoy it. So good to see you all.
Oh, it's me. Thank you. Yes, so thank you very much, Brendan, for launching our music therapy research lecture series, and for you all being here. Thank you for joining us. And as Brendan mentioned, we are live streaming, so some people watch it for the comfort of their own homes. It's great to see so many here as well. So welcome, and welcome, Sana. Thank you. Was I going to be here? Yes, I wanted to just say a little bit about how Sana came to be here, but quickly, because I don't want to take up your time. We tried to work out when it was that Sana and I met, and it's a little bit blurry. But we did overlap with our PhDs in Aalborg in 2010, and we do know that Tony Wigram introduced us. But where and when remains a bit blurry, so it's been some time ago. And it was in 2016 that we talked in Vienna about you coming and speaking here. So it's taken us 3 years, but I'm really delighted that it's worked. And the reason it's worked is that we've collaborated with the fabulous Mary Campbell, you know her, singer-songwriter, and Sana, you're working with Mary this weekend on this more and offering a voice weekend, but right, a retreat.
Yes.
So I don't know if there's spaces. If anyone's free for the weekend, talk to Sana at the end. So thank you very much for coming, Sana. And yes, for this actually coming together and taking place. It's great. Over to you. We're delighted you're here. Welcome, Sana.
Well, I'm really happy to be here, and I'm really happy about our collaboration. And we succeeded, yes.
Yes, we did.
We did. Yes, so I really hope this is a topic that you will enjoy to listen to. It's two topics that stays very close to my heart, and which I'm very passionate about. So it's research into the human voice as a primary instrument in music therapy, and I'm going to talk a little bit about voice assessment, which I developed during my PhD study, and also group music therapy with women suffering from depression and anxiety during postnatal after giving birth. So I'm working at the National Hospital in the Faroe Islands at Psychiatric Center. So this is the National Hospital, Faroe Islands. So you can see it's close to the sea and mountains on the back here. But all this is the hospital. Yeah. So just last week, there was a focus on mental health because it matters, and was actually also one of the things that we talked about. This subject is really something that might not have been so known to many because there's actually, when we're focusing on this population, there is actually quite a lot suffering and in need of early interventions of some kind. And they are really eager that it's not medical treatment, but some other opportunities to get well. So in the Faroe Islands, we had a pilot study in 2012, and it turned out to show that it was 12% of all the women in the Faroe Islands who gave birth that year that actually was in a need for some kind of early intervention. It had different intensities of need, but it is 12%. So when we're speaking about 612, 15 women, it's around 60, 70 women, families, and also we are thinking about the children just being born. Yeah, so we will repeat this. This, what I'm going, the focus on music therapy is actually a little part in a huge research project focusing on early intervention towards perinatal anxiety and depression in the Faroe Islands, and it's a sectorial shared care organization. And it is because I started with working with this population as a music therapist in 2010, together with the health visitors and a nurse at our department. And then we have built it up. And what we found was that when the health visitors was offering screening and found that some of the women were in need of early intervention, then they had to refer it to the general practitioner, and the general practitioner had to refer it to some other people, the psychologist or our team or somebody else. And then 8 weeks passed on, maybe. And that's quite a long time when you just have given birth and you have a newborn child and this interaction, and to make secure attachments possible. And so making the good conditions for that. So the research project is actually making it possible for the health visitors to refer directly to our team, which is an interdisciplinary perinatal treatment team. And this is showing how we collaborate very close together. The general practitioner can contact the health visitors, opposite way around. We really can cross each other very quickly. So when the health visitors is offering screening, or the midwives, as it is in this project, if they find somebody in need for early intervention, they can contact us directly. So this is what I think of early interventions. And this is hopefully what will bring some results about, to see that it matters also. But this is an organization that is not so known, and it's not done so much outside. So this is a way of organizing that I hope to be able to explain more about in a year. The interdisciplinary perinatal treatment team is me as a team leader, and I'm partly researcher and music therapist. Then there is a psychologist connected to the team as well, and a social worker as a consultant, because there will also be some kind of things there. And then 2 nurses educated in basic cognitive therapy, and having a lot of years of experience within the field of nursing within psychiatry and so. And then I have got some funding, which made it possible for me to get a music therapist half-time, and she is collecting the music therapeutic data. So I'm doing the clinical work, and there she is collecting the music therapeutic data and other similar areas. Yeah. And then there is the psychiatrist, which is, of course, it's a part of, it's, right now it's placed within the psychiatry because it's a whole new thing going on here. So, but we will see what happens when we have come to some results. Is it necessary to have it placed here, or could we actually put it out closer to the general practitioner or the health visitors or the midwife? So it's a primary service and not a hospital service. Because there's many of these women who doesn't take medicine or is in need of medicine, and it's also my clinical experience right now that it is better to maybe have it outside the hospital area. There's also some insurance problems and bank issues to consider there, but I'm not getting to that. But, so what do we know actually? Many years ago, Trevor, you when your research was focusing on the interaction between mothers and children. And what you posted there was that it was audible in the mother's voice, and that this, when the depression was there, it was audible in the voice, and it also affected the interaction. So later on, there was Lynn Murray and Modic who published an article where they really pointed out that according to international experience, many episodes of anti and post-depression go undetected and untreated. And therefore, they suggested that we should have an increasing professional awareness of effects of depression on the human voice that may enable us to discover it a bit before and be aware of it a bit before, and identify and treat postnatal depression. So this was an article I read while I was doing my PhD study and developing this voice assessment tool. So it was really putting energy in my work. Just last year, there was an article published where it was making more definition and more specific definitions about when it's untreated postnatal depression. Then the children of mothers with brief postnatal depression has more behavioral problems when turning 3 years old than mothers who did not have a postnatal depression. And it's getting worse if it's more severe depression, because then it's also problems just again 3 years old, but also when they are teenagers, and when the learning abilities is also a bit troubling, and there is also a higher risk of those children to get a depression themselves. So therefore, it really is important that we have some early interactions and do preserve the conditions to be as good as possible for the children when they are newborn. Then last year also there was an article published where it was examined singing compared with standard care and play therapy. And it was singing, just singing songs and doing things together with the babies and so. And what was found was that there was a significant more beneficial outcome with the mothers who were singing compared to standard treatment and play therapy. So this I really looking forward also to see what is my results and going to be, but because it's not just singing, it's also doing very concrete vocal exercises. Then there is my assessment tool, which I did in my PhD study, which is here. It's it's a big book, but it is work about developing this assessment tool and doing research into if it's possible and if it also made clinical sense to do it, actually. And I came so far that I did explore that it made sense to apply it in clinical practice, because it has the potential to capture even small movement and changes in the voice and then support the clinical evaluation. And it really picks out those moments before you actually are conscious about the movement of your recovery or the movement of the relapse of your state of being, so that before it's also conscious around the staff. So in that way, it might be something that could be worthwhile trying to apply even more. So that's what I'm doing here with this population and these women, and taking the voice into this group. So just to give you a picture of how I have worked it out with just one parameter. There's a lot of parameters being evaluated and measured, and then of course after doing that, that's the simple part. Actually, you have to make the analysis, and the analysis has to make sense psychologically. Also according to what does it make sense to the client, does it make sense clinically? So, and this is the hard one, and this is here. Training is really needed, and where you need to have some self-experience in how to use the voice and how it affects you, how it affects your state of being and emotions and so on. What you're looking at here is one person singing one note, just one tone, maybe like this, and then you will know that there is a fundamental frequency, and to make the timbre and the quality of the sound, there also is overtones present. And as you can see in the top in the picture here, that is in the first session, and then over time they had a treatment running over 12 sessions. So this is the picture of the sound in the first session, and then you can see how the voice quality, how it's actually coming more alive in the picture over time. And this is also the sensation which is really happening within you, and which actually put myself in that position that I really want to do more research into this, because it's so clear. It's so clear how the body sensation is changing, how you are feeling much more empowered and having much more vitality present. So just about working through voice and how you can actually work with you, allowing your voice to be present, to take space, and it goes well together with everything actually. So yeah, so continuing to present to you what the music therapeutic part is in this project. It has focused on strengthening the psychometrics of the voice assessment profile and to increase the clinical applicability of voice. Yeah. But it's also because when I'm working, and I have really done it most of the time when, as a music therapist, I have used body and voice work, and I use it very specific interventions actually, and it's just a variation of some core interventions. And it's very important also to notice that they are without words. They are free from semantics and linguistics. So the voice profile itself is also usable, more universal, you might say, because it's taken out of this context that the language is putting in some, you have to rephrase or reconsider the analysis outcome. Here you only have the sound. It's the sound of your voice and the voice quality and how it is present. And you might ask, can't you fake it? But what I found out in my PhD study was actually that, because there was a theater woman attending, and she was really depressed when she started, and she couldn't fake it. She really came to me because she couldn't control the sound of her voice. So, and she knew she didn't have a cold, so it was really about how we could work through this in a psychological way of understanding voice work, and how this affected her state of being, and coming back. So I have found out during the years that actually the way I have introducing these local intervention is bringing it to a very authentic expression. So the data collection focusing on voice will be from 4 categories, because when focusing on this population, I'm trying to explore if there are something which make it very audible for the group where there is a special need for early intervention. So does this group differ from the first group where there's no need for intervention? So collecting voice data, and it's one assessment, one session, one meeting, and women will voices will be collected from women in this category 0 to 9 and 10 to 12 and 19 points. And these 3 categories go together with those planned interventions we have as a health service. When the women, the health visitors or the midwives discover a person scoring 10 to 12, then they offer 2 more consultations where they are focusing on the well-being and having a talk and interaction with the family and what can we do, and having some guidelines there. And if it's 13 points, then there is the possibility to refer to our team. Then I also collect from non-clinical women, so I have a kind of possibility to compare. And it's women not pregnant and who has not just given birth within a year, and they are tested for not being depressed or having anxiety and a good well-being. So the voice assessment is 3 core vocal interventions. And it's an open descender movement where you are asked to start with the deepest possible tone, like, then you move upwards, and then you take an inner breath. And what you then go into, of course, you do it more in flow, like you're asking that. So this is the exercise for that, and it will be analyzed according to many different parameters defined there. And then there is the core tone, which is about giving sound to one single tone. And the last bit is about the free improvisation, which I, in this context, call, because it's free and it's actually a song from the self, you might call it. So it's song of the self. So the voice assessment involves observing and evaluating the human voice from many different perspectives. And it's vocal exercises chosen, they are free, as I mentioned before, from semantics and linguistics. It's also important to notice that it's not spontaneously. They are guided into something specific and then sounding these exercises. And then the protocol itself, how you're guided through the whole assessment protocol, it's really very fluent, and one thing is really naturally leading to the next. So it's starting by stabilizing and grounding people, and then gently opening up to and applying the free exercises accordingly. Of course, it will flow in complexity, so I will always end with the free improvisation, because that is a complex thing to ask people for the first time, never been there before, first meeting ever, and then have to ask, but still. So that is also the question, is this too much to ask for? Actually, but I will come back to that here, because what I do in this research project also is to ask all those who has come and been assessed once, and who has been met by my research assistant once. They are asked to answer in a Likert scale if the exercises were easy to understand, if the exercises were easy to perform, did I feel safe in these conditions, and did I engage in the exercises? Was it a good experience to me? Yeah, and was this in a very not familiar way for me to use my voice? Did I discuss new things? And the yellow colored here, you can see that most of them, this is non-clinical women, and so far I have collected 21 women, non-clinical, and 21 of them actually say it was easy to understand, and most of them also said it was easy to perform, and most of them also say that it was not hard to concentrate on this exercise, and then the most I engaged in the exercise, it was a good experience, and I also felt safe, and this I find really important. I was happy about this because it's then I can easier say that it may be okay. It's not so. It might be okay, yeah. And Then I have collected from the 6 women in a pilot study about giving group therapy right now, and you can see the same pattern here. They actually answer the questions in the same way. So if you look back and forward, it's exactly the same pattern. So we will see. In a year, I know more about this more secure ground. So what I'm aiming to do here is actually, and it's also needed within music therapy at all, it is to provide a discussion about processes and mechanisms that are expected or elicited through specific body and vocal exercise interventions and exercises, and to collect data to substantiate these figures. And then I'm also aiming to explicate the applying specific interventions, predicate on theories and about outcomes expected from the interventions and associated therapeutic processes. And I'm hoping to be able to examine the relationship between expected outcomes and specific symptoms of depression as identified in ICD manuals. So, because when I'm collecting from the therapy process, people coming and getting music therapy where it's body and voice work interventions that I'm applying, then they are always tested in the beginning and in the end with Beck's anxiety and depression scale, as well as a well-being test. Because sometimes it's got to put things upside down and look, ask for something different. And then I'm also having voice here. I'm having voice follow those test tools. So I can see if voice is actually exploring if it's possible to, does it give me more information or does it give the same information? What kind of information? So I can see how voice work together with this. And then after having a therapy treatment, the woman is asked to join a qualitative interview where it's semi-structured, and so I will get the subjective experience of actually working in this way and doing therapy in this way. Because I know why I do the exercises, but what do they experience? Is that actually what they experience as well? And I find that it's really important to gather that information so we know something about that. And then also to evaluate it more quantitatively according to a Likert scale. So when I apply this approach, my focus is actually not on the signs of depression or signs of anxiety. It's my focus is in supporting some very basic conditions we have as a human being, because I think that is what body work can do, and really good, and it's a powerful instrument for that. And so you can see this figure here. It's a tumbler. I don't know what you call it in English, but it's a toy tool with a round button, and when you have the children, and so they will push it, and then it will, but it will never come. What do you call it? A tumbler. Yeah. Okay. Yeah. Good. I was searching a bit, but the fact. But I have found that because I'm almost every time I'm meeting people for the first time and we are talking about their well-being, so they are always, many are talking about how they feel that their feet are swept away, they have lost their contact to the ground, they are out of focus, or they can't find the way, and it's just like everything is out in the head. So everything is going on here in the head. Many thoughts and many speculations and things like that. And what I then aim to do with my body and yoga intervention is to go in and support getting into your body, embodying yourself and being centered, and having this inner sensation of centering, growing, and being strong and empowered. And while doing that, it's a kind of empowerment according to, because when you're grounded, when you're having good grip on yourself in this centering sensation, then you can manage to feel the difficult, allow the difficult feelings to be there. You will not cut, or you will not be afraid of them. You can actually cope with them, or you can contain them. And although you are vulnerable, so and maybe also you know that, but it's okay. It's about having both sensations at the same time. So it's about actually feeling empowered to be able to be in it, stay with it, and to make some actions to it. So in that way, actually, it's also about strengthening self-confidence and self-esteem and empower the ability to act. And it's about strengthening the ability to self-soothing, because all the exercises that I'm applying is actually so simple that they can take it with them home and do it themselves also. But of course, there's a need when you are not so well, there's a need of meeting up with someone and doing it together. And then while you have embodied those exercises yourself, then you can use it at home and you will start doing that. And I have experienced that as a clinician, that they are doing that. So in that way, you are actually supporting how you can contain yourself and you can contain others. And when we are thinking about mother and child, it's not always a happy moment, because there can be difficulties with the baby. It can cry a lot. It can have trouble with flukes or other things which is really sore to them, or in some kind of a way. And if the mother is not feeling well and really have this feeling of being swept away, then the ability of containing this is not so good. So, but here we can go in and support and strengthen and yes. So it's always about supporting also the understanding of how body, feelings, and thoughts are connected. And so it's always an ongoing discipline in training the listening in a broad sense of understanding. So it's about listening to all kinds of signs, but also listen to a way of being aware of what is going on, what is happening within you, and understanding, but also understanding and noticing that when you are taking an action, how does this affect my state of being? And it's very clear also, because in a very short time, the state of being can change when you're using body and voice work in this way, because you can really stabilize a very high kind of anxiety feeling, and then stabilize and ground it actually, and you can feel the breathing is changing, and you can feel that it's more relaxed in your body. So you have immediately this experience of this works, this I can do something which is changing my state of being. So I have something I can do myself. And so in that way it's powerful, because it gives something to the women who asks, what can I do instead of taking medicine to this state of being? Can I do something myself to tell me and guide me in what way? And just to have this experience that it works to do something. Yeah. So it's really about, it's a bottom-up process. It's really very bodily orientation, this one. And it is about coming into the autonomic nervous system, sensing and getting feelings and how it affects your way of reflecting and how if you then can come back. But it's really, it's a bodily, it starts in the body and it moves up. It's not something you talk about how, So it's really about this, the experience is really essential. And it's, yeah. So, coming back to something you also have written about some years ago, and in kind of the importance of what is actually happening when we're sounding together, and when it's so and it's without words, and so it's a simplified way of being together and creating some noble affective attunements. So it's really about how you simplify and make a better condition for being synchronized and really being in tune. And I have really experienced that although it's one single tone that you're singing, then it's a very broad and very deep pictures and very deep experiences which is appearing. It's not only one thing, it's like a whole world is opening up actually. So although it's very simple, it can open up to really big experiences. And this you share actually, and it might sound weird, but there is an intensity in the present, the way you're present and the way you're being together while sounding, which is making it much intensive and really empowering, and it's a really powerful word. So this about sharing the sounding is it's really moving in all aspects, both cognitively and emotionally, bodily, and also what you share culturally and socially. Yeah. So what the youth Ravan called it was also centric mirroring, yeah, and so with other resonance in an intersubjective matrix. So just to, because I'm using drawing quite a lot, and I'm using it within the same sessions, it's about and trying to capture the sensations within and put it into a paper drawing, and because then you can talk out of this, you can put words into it, and you can be more conscious about what is actually going on, and this is the sensation we start with. Then we work and we have another drawing. So just as an example here, there's a woman suffering from postnatal depression, and what she described when she came to the therapy and we made this drawing was that in the middle here, there is life. And there is a thin ring around this, holding it, but also keeping it out, keeping it from being expressed. So she told me that many of these things here going in towards the ring and the life within is many negative thoughts about herself. It was so, and these actually maybe was the things which kept the ring in fixed. So we started to work using body and vocal interventions, and after doing that, and where the process actually was from starting singing one single tone, and then this time in this session, she followed an impulse she got about allowing herself to sing freely, allowing the song to develop and really take the space, and so I could hear it. I kept as a stable thing, I kept the chord tone running always, but she allowed herself to follow the impulse of making a free vocal improvisation. And after that experience, she said, and she drew this for the first thing, and really the words connected to her from her was that for the first time she recognized her own voice. I recognized myself, and there was no negativity, and it was a feeling of freedom, to be free somehow. So in that moment, she made something which was possible to loosen up and be free. So the structure of the group therapy that we had as a pilot study here, where I really push it. I push it so much that the verbal part of it is not so much, because I really wanted to try out that it's the work doing the job, and it's about how this actually can be enough. It's a question from you, but so the way I structured the session is also about how I can structure the verbal rounds, so it's not taking too much space, because many times it's very common that in psychotherapy and group therapy we start with now what's happening, what has happened since last time, what has happened during the week, what is important, and then you speak and speak and speak and speak, and it can be very good to hear those stories. But what I actually found out by pushing it a bit and really put a structure into how what you were going to talk about, by making some very gentle body and vocal exercises as a start, as a now we are here, now we are coming and being present here together, and then sitting down, focusing, listening, as I told you before, listening within, and really listen to what is the sensation within you right now. And now then really allow it to take form and shape, and try to picture how can I put this into a drawing. And then they do that, and then I even ask them to pick three words essential to capture the wholeness of the experience. So in that way, I really make a support for focusing what is important, what is really important, what is the most present thing right now, in the moment here where we are meeting. So we take the verbal round and we show each other the papers, the drawings, and have a little talk. Showing the names, the words, and so on, and having a little talk. It's very focused talk, and it's really focused on what's really important right now. And then after this round, we go into more intensive body and voice work, and then we do the same thing, listening and drawing and having a verbal round, and then we compare the two and see what is going on, what is happening from the beginning to the end. What has come forward, what is important of this, and ending everything with a guided relaxation and maybe singing a song together. So what's the result in the pilot study? They were tested with the Beck's anxiety and the depression scale, and it was only 8 sessions. So we have a 32 years old mother and 2. And the father is a sailor, and the anxiety is not so much, but as you can see the yellow mark here, at the beginning she's moderate depression, and after 8 sessions there was no depressive signs, and also the well-being was growing, but the significant part of movement was from moderate depression to no signs. It's actually quite quick movement if you're thinking about 8 sessions and so. And another woman, 20 years old, mother, first time, also father is saying that this is where, that's why I'm applying also this questionnaire out in the midwives and the health visitors to gain some demographic data, because I really have an idea that because we are coming, there are many women alone a lot of the time while the husband is out sailing for some weeks and then come back maybe 1 week and out again. So I have an idea that when the second and the third child are coming, it's really getting tough. But we'll see. But then this one woman here, 28, she really scored moderate anxiety, but after 8 sessions, no anxiety signs. And she even scored severe depression, but after 8 sessions, no depression signs. And the well-being was really growing from up above school. So it was really nice. And then there's a 37 years old mother of 3, Sarah as well, and where the anxiety grew, but it was, I analyzed it in that way that she was not so conscious about how much the anxiety actually was taking place and how it showed itself. So over time, during these sessions, she became more aware of how the anxiety was present. But as you can see, she scored severe depressed and changed it during over 8 weeks to mildly depressed. So it's a big jump from being suffering from signs of depression and so. And it was a big mixed group. There was also 2 women where this one, 35 years old, she has been hospitalized with nightly psychosis, and she was also in medical treatment. But what was needed now for her was actually to stabilize and embody everything. So really give it time to take a good grip within. So she was joining the group in that way, but still there was a movement accordingly to a growing of well-being. And then there was another woman here, 35 years old, where it was a bit mixture, and she was having a bipolar disorder, and she was really having rapid shifts in experiencing depressive and more energy, and then again depressive. And so, but it was really important what she told me as I told my research assistant in the interview afterwards, that the work provides energy. So during the session, she gained more energy, and it was a way, she said it was a way to listen to herself and to be present, and also putting thoughts into a force somehow. And the thing that we were singing together, she experienced very powerful, and also it was important for her to actually experience that it's possible to recover and to witness that, because that gave her hope. So it's not necessarily a bad thing to take part, although nothing really is that it's not happening so quickly to everybody. So just to show you again, drawing from the beginning, the only thing here was that I wish to be home in bed and not get up, really heavy sensation in the body, and really feeling down. And so, and after work, she was doing this, where a lot starting life to come forward again and feeling energy and also feeling lighter sensation in the body. So, and this is exactly what I think it's doing. It can put your body in motion, and this kind of work, and actually put some energy in it, so then get some flow into the body, and then hopefully it can stay for some time. But then you need a new injection of empowerment, you might say. So, but it's nice to see, because this was very typical that actually happened something, but for how long did it stay afterwards? But I think it was important to gain, and anyone to have these experiences. And then another thing about being more conscious about things was that it was feeling in the beginning warm and stability. It was good, but then there was also this not something not so good. Here, this was there was something which was not conscious, and which was what I'm dealing with here, but it's bothering me. it's really preventative and not allowing me to feel all happy. So, but afterwards, what she realized after the work was that maybe actually she was starting to ask herself, was she standing in her own way? Was she as actually stopping herself by not allowing herself? So she really started to ask that I need to put myself more out there. I need to say what I need. I need to tell them that I need help. I need to say to my husband, stay at home or whatever. And it's about this giving voice to something and really put it out there, not just carry it within, but really put it out there. So the work is also about taking that chance of putting something out there, which is without words, but audible. You can hear it. We all can hear it. And I can see it. So in that way, you are really getting this empowerment. The last bit, is that okay? Everybody? Yeah. It's just a small, because of a pregnant woman, I will tell you. Because I collect data from birth casualties. So, Mila, she was just 8 weeks before giving birth. And she was really scared about giving birth and the pain connected to giving birth. And so she's in her late 20s. She's expecting her first child. She's living together with her husband. And there's a really good stability and good support around her. So she has all the good conditions. But still, there is something which made her score in the EPDS, Edinburgh Postnatal Depression Scale, so much with 14 points, where the COT score is 13. And so she was in need of more early interventions. And the husband also joined some of the sessions and doing the work together. So in the kind of preparation for delivery. So in the first session, we were identifying that she actually had a moderate to severe depression signs according to Beck's test. She was sad, she was unhappy, and loss of interest, and tired, and loss of energy, and really a lot of worrying thoughts and the negative thoughts, and especially just in that moment where she was going to sleep, because then came on. And during the day, she also experienced that it was difficult to concentrate, and she was, irritating, yeah, and had less patience, so she had outbursts of some kind in between. So, but she really also had difficulties in getting up in the mornings, and then we did some work, different kinds, the same way, and what was found out was actually that she also had panic attacks. She didn't really realize that in the beginning, but that is also my feeling. It's really interesting that sometimes you don't know how it feels to be anxious, but the body shows it's full of tension, and it's really, and you hardly breathe and everything, but you don't connect those things with being afraid. But what we did we found out it was actually panic attacks she had in between, and she was really anxious and afraid of delivering the child and so. And she had this heavy body sensation and sometimes even soreness and physical soreness and somatic pain in one. And in a way, when this was present, this soreness, physical soreness, then she really felt helpless and not able to do anything about it. And it blocked her in any way of take action. But what we found out was that it was connected to an earlier experience where she was hospitalized for quite a long time, almost a year. And during that year, she was really having severe body pain and severe somatic pain. So what brought her back here during the body and voice work was to come back to this sensation and connect the dots, you might say. And she also told me about that after that episode, she actually every winter had a relapse and some depressive signs. So, and she was going into that period after a year and having to give birth during the autumn, and having to be the new mother in the winter time. So she was really, the concern was about that. So 8 sessions, and what happened, so a quick overview. Pre-experience of somatic pain is sitting in the body. I think it's something the body remembers, and it's something very terrible. It's not something good. So it's about dealing with that. How can I recover from that? So the process was a movement from being overwhelmed and frustrated, unhappy, and suffering from these panic attacks, and being unable to act into a feeling of being encouraged and believing in herself and trusting herself, handling panic attacks, as well as the body pain, how it was connected with contractions and giving birth and so. And what she really experienced as a success was that at a certain point she started to get contractions at home, and she really immediately had this reflex of getting anxious about it. But then she took some of the exercises that we had been doing, and she was really using them. And then she had this, I control it. I managed to be with it, stay with it, and not to be run away in my mind or anything. So for that, in that way, it was success. So just to give 5 different experiences from herself. You can see here from Nina's perspective. Afterwards, and after delivering her child and so, she was interviewed, and she said that I'm more calm and I listen to music every day, and this support rests without any thoughts, which usually is present. It supports peace and a feeling of joy. Me and my husband listen very much to music also together with our little daughter. We have, all 3 of us, had good experience and effectiveness. I do not think any of the exercises were difficult. However, in the beginning, I found exercises focusing on breathing difficult. I'm doing this using the sigh, the sound of the sigh, as because like it's really supporting you to. Then, if you empty your lungs, then you immediately expand what amount of air you breathe in, and then in that way you actually expand just gently over time. So that was those things she found very difficult, because I'm not good at focusing on breathing, because I immediately want to take control, and this is not unusual either. There's many who wants to do that, to take control in some way with the mind. And but as we did the exercise, I learned to have focus on the breathing without taking control. And there was especially 3 exercises that she found good. The first is where we are standing on the floor and relaxing the body and really shake. And it's about doing this that I vocalized just before. And making a kind of like body movement, making the body being heavy. And then this is supporting her to relax and calm when having anxiety. Another exercise was when I was guided into an altered state of being and discovered pictures, which provided me with a new view upon myself and my state of being. She had an experience with, and explained here, that I saw who I was as a whole, without the illness. So this gave me an experience, a different experience of myself. So here she actually told me that the last piece of in the puzzle was put into the picture after the sensation of that year with the somatic pains, and so here she was able to differ herself and just see herself as the whole person without that. So it was very important. I have learned that I'm much stronger than I thought. Although troubled times has given some marks, I'm still me. And although others may think differently about me than I think of myself, I know who I am. And this is what matters. I was afraid that my way of reacting to much pain in the body would affect my feelings towards my child after giving birth. I was afraid to get postnatal depression, but I did not receive this. I have learned to react differently to bodily pain. The thought is no longer this has no end, but rather this is right now, but it will change. And then the state is different. I can make the best out of the present situation. So, with those words, I will close and just tell you that the research project is funded by the Health Insurance Fund in the Philippines. Yeah, and thank you for your
Thank you very much. There's quite a lot to think about, isn't there? Brilliant work. Thank you so much for sharing. I'm just impressed at the team that you're leading and the context for this research. That's obviously been going on for years, not just this project.
It's built up.
I've got questions about research.
Now it's very lovely to hear some questions and to get into a dialogue about what you may think.
I was looking for two words, and one of them popped up once, I think. It was joy.
Yeah.
And the other one was pride.
Yeah.
Now, you were speaking about them a lot, and you actually didn't name them, and it doesn't matter, but I think they're so important for what's called well-being. It really means pride.
Yeah.
It's interpersonal, not just.
No, exactly. Yeah.
I was wondering also why. I mean, there were plenty of citations of me, which I don't need. But what about Daniel Stern?
Yes, but he's definitely
very far ahead of most of these
things,
and of any idea of the present moment and so forth, vitality dynamics.
Yes. Yeah, and this I built everything on that.
He knew about dance. I mean, he was a practitioner of dance, not in song.
No.
But he did writes about it in a way that makes it clear.
I really found his book about vitality forms going really, it fits really together with this kind of work.
Strong,
Yeah,
he's wonderful.
Yeah. So it's when we're talking about what is actually happening and putting words into it, then that book is really offering some good theory to understand this kind of work, with its movement in many ways, feelings and body and mind, and so I can recommend that. Hardly it was my Bible during developing my voice assessment. So,
I'm thinking about the assessment and the research process. So I guess what I'm wondering is that from your experience, lots of the outcomes, if you like, the health benefits, you could say, I know that, I've been doing this for years, it's not a surprising outcome. I know that, that the power of using voice can have this kind of implications for people. But I'm wondering, so the different assessment tools that you use, but also one that you developed, from what you're presenting, had the function around diagnosis, whether people were fitting certain criteria to be referred to research or not. And then another assessment procedure was about documenting change. What has been the impact of. But I'm wondering whether there has been an element of assessment of your practice. Like, have there been things that you found, oh, that's surprising, or findings that may challenge your practice or took your practice in places where you felt, I was not expecting that. It's kind of was there anything surprising for you from using these assessments, or was it all a confirmation simply of, I knew that, it's lovely to have it from an assessment tool, I can go back to the funder and say, give me more money.
No, because it's still surprising to me, because I actually don't quite know what is the voice assessment telling me, but I'm coming more close to it. But it's definitely because when you start developing something, then it's because sometimes you have an idea that you will get some answers, specific answers. But just as I have found out during the years, because I've been able to work for a long time with this population and for a long time with the same method, and really been strict to myself about what kind of exercises I apply. And so then I have, it is not so long ago that I discovered that this way of working is go across diagnosis. It's something going in and supporting something which go across diagnosis. So, and it's really interesting because the clinical experience is that, and this is really astonishing because I do exactly the same, although that person is manic, or a person is depressed, or is suffering from anxiety, but it has different impact. And but it's exactly the same thing. And this I didn't know. I didn't know that then the question is, what is it actually doing? Because and that's why I'm starting to focus a bit on that. It's going in and supporting some very basic conditions within us as human beings, actually. But that was not my first thought. So that's about the clinical practice, and so. But according to the voice assessment, it's also, I'm still very unsure, and I'm very humble about it. Maybe I don't find anything. Maybe it's still not possible or anything, and maybe the sound of the hook as a, who knows, as a, maybe there will be some small things, and then but it's not, yeah, we'll see in a year or so. I know a bit more about that, but it's really, I'm really feeling quite insecure, and in between I'm not trusting it at all, and then yes, I have to keep on going, this is good, and so, and then crashing. But I think it's what really keep me going is that sometimes there's this clinical thing where it really makes sense, and that is something which is so clear. It's definitely so clear that it could not be described in words, but it's pictured there somehow. Yeah, I don't know if that's answer. Yeah.
I think that two people could, that you probably are familiar with, that can give you support. Is not very conventional way. It's Panksepp, Panksepp on the FH.
Oh yeah.
And not in the same way, but also Alan Shaw.
Yeah. Yes, about the nervous system and so.
Yes, the relationship.
Yeah.
Incidentally, it's very interesting that these things are so different for male and female voices. I mean,
I beg your pardon.
When you're talking about, most of this is dealing with the voice.
Yeah. Yeah.
As a female with a female.
Yeah. Yeah.
And,
Yeah.
I mean, that's, I'm thinking Alan Shaw is, because he finds that most of his effective neuroscience is dealing with something that is very strong in women and develops early in babies.
Yeah.
Female
Okay.
babies.
Yeah. Okay. Yeah. 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 Yeah.
But you didn't say much about baby vocalizations.
No. No, I didn't. and
Because they echo, don't they? They echo a lot of the things that.
Yeah. I have really considered this. Should I have the babies within the group therapy, or should I not have it? I really had this discussion, and some years ago I allowed the babies to come in, and but it's really difficult in the Faroe Islands anyway, because there, as together a group, is not so easy, because then how to group them so they fit, as the group fit, you might say, so the dynamics in the group is good, and so sometimes you're not able to have a group, because there's long between when the people is referred, and then suddenly, but they don't fit together, and then there's the babies are in different ages and everything, and I couldn't really manage that somehow, because, and it also, what I also discovered was that the possibility for the mothers to actually put themselves out there and do something to their own situation and really put aside for just a moment and focus on themselves was maybe a very important step also. So then I considered to have a babysitter. So the babies were close by, but having a colleague being with the children, and then I worked with the mothers. Yeah. And then because what I hope is to boost some energy and some empower the women's voices so much that it's actually affecting the interaction between the mother and the child. Yeah. But I would really love to have focus on and study the vocalization in between those, as what is actually.
Also, you know, the work of the people in Lisbon, Paul and Nicola and Elena Rodriguez.
Yeah, but
they violate a lot of principles of privacy and so forth. They do a lot of work with spontaneous groups. Babies with their parents and so on.
Yeah.
And they make a group situation. Yeah. And they use art of different kinds of artists, dancers and singers to animate.
Yeah.
And that's what sometimes.
Yeah.
Well, it does have beneficial effects.
Yeah.
It's complementary. It's a different approach.
Yeah.
I'm sorry, complementary?
Yes.
What's the approach?
Well, it's an approach which uses theatrical performances in groups, even with tiny babies, and it's used therapeutically.
Yeah.
The company is the theatre, that's right. Music of the company, something like that. I can't remember the Portuguese, but their work is very inspiring. It's a bit wild in a way.
Yeah.
But it works. I mean, it's amazing how well even tiny babies put up with this drama.
Yeah, I guess that was my question as well. Was about, because you said at the beginning, you started off and said the analysis has to make sense to the clients.
Yeah.
And then throughout, there was kind of hints of the fact that they would be doing other things out with your sessions. They were taking musical resources, they were learning things, and then they were using them now somewhere else. And I was really interested to whether you have been measuring that as well, the sense of what they've taken from the kind of synchrony in your relationship, how that then taken into other places.
So just as the last case story about where she points out that three specific exercises which helped her. I hope to get a lot of information like that as of during next year, so I can get brought it out and really have a broad description of how these exercises is experienced, and also as going into and see in what way do they use them.
Yeah, because I was intrigued they were also listening to music, so not just using the exercise, but maybe even listening to music in a different way.
Yeah. Yes, and especially one right now is really taking this tool as really listening to himself, putting a drawing. She has been drawing for 2 years every day. So really, because that supports her to really stay with it and not getting away, her attention away from being present here. And then she also sometimes vocalizes. I use one of the chord exercises and using it at home to support to come back to herself in some way. And so it's many different things they do, that they pick it up. So many of them pick it up and use it. And then when they are feeling well, they forget it. And as we all do, so maybe we practice yoga or we practice whatever because we know this is good for us. But then suddenly we don't do it. And then we have to remember it again when we are not feeling so on top of everything, that it's a good thing to do. And I hoped for that it will be present in that way. Yeah. But I hope that the interviews will tell more about that.
Yeah, it's really interesting.
Yeah.
I'm going to pause for a minute, I think, because I'm aware we've run over time. So can we, first of all, I mean, it's so brilliant to hear your work. I love your approach, and I think you're just open, and so thank you very much for sharing it with us, Anna. I wonder if we should finish up now, but we won't run away if there are other questions. Is that okay? I'm just aware people on campus holding the room, live streaming and everything for us. So what we'll do is finish up now, but we can carry on the conversation.
If you have any mail,
Yes.
if you have any mail or something, maybe we can.
You can go by. So
Yes. If you're.
But join me. Thank you very, very much.
Yes. Thank you. Yeah.
Well, I know I'm very I will be better.
We should stay.
I will send it to you and it's learning more. So,